All right, good afternoon, everyone, and welcome to the Immune Deficiency Foundation's Lunch and Learn series. Today's program will explore CGD with Dr. Jennifer Leiding. My name is Emma Mertens, and I'm the Program Manager of Community Relations at IDF. On behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us today for this Lunch and Learn. We are excited to host this webinar for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your journey. Today's Lunch and Learn is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. We'd like to thank our partners for today, the CGD Association of America and Horizon Therapeutics, for supporting this program. We will be hearing from them both later on in today's presentation. Before we begin, I would like to point out a few housekeeping items to keep in mind for today's Lunch and Learn. This afternoon, we are using the Zoom webinar feature. Attendees should be able to see the slides and our panelists and be able to hear myself and the presenters speak. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions at the end of the presentation, and you are welcome to submit any questions you have as you think of them throughout the session. Please type them in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember that information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We're here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. To learn about IDF and explore our resources, please visit our website at www.primaryimmune.org. The website offers a wide variety of online and printable resources for anyone seeking information or support for PI. This includes the Patient and Family Handbook for Primary Immunodeficiency Diseases, which includes a chapter dedicated to CGD. We encourage you to visit the IDF Resource Center, where you can find all of our publications, videos, news, and more. We also encourage you to check out IDF's Living with CGD website, which can be found at www.primaryimmune.org/living-with-CGD. The website has tons of information on what to expect with the CGD diagnosis, and topics cover every step in a family's journey with CGD, from pre-diagnosis to diagnosis to treatment options and planning for the future. IDF also offers monthly programming and events. In addition to our Lunch and Learns, we host 2 IDF forums a month, and we also have Get Connected groups, peer support, and Ask IDF. We are also thinking of ways to bring the latest in PI to you, such as the 2022 Primary Immunodeficiency Conference. We hope you will save the date for this event coming up this October. And now I am so pleased to introduce to you our first speaker today, Felicia Morton, the Executive Director of the CGD Association of America. Welcome, Felicia.
Hi, thank you so much. I am really pleased to be here today to talk about the CGD Association of America and to be a part of this really important discussion about CGD and X-linked carriers of CGD. I started the CGD Association because my son had been diagnosed with CGD in 2012 when he was 5 months old. And I know how it feels to get that devastating diagnosis as a mom and not knowing where to turn. And I am so grateful to the other mothers out there who had sons with CGD who helped lead the way for me and for my family. He has since had a successful stem cell transplant. And I have really dedicated myself to helping other parents and patients navigate the path forward with CGD. In 2019, I started the CGD Association of America, and our mission is to provide independent news and information to help patients and carriers make decisions about their treatment path, and also to advance research. We offer many different opportunities to get together and to learn together. We have, for example, the Coffee and Carriers talks. You can go on our website and find out when those take place. It's an opportunity for female carriers to get together online via Zoom and talk about what they're going through, and to learn about the health issues and ailments they might face, and also to discuss resources available for their children. We also produce several educational guides. We have the X-Linked Carrier Guide, which is a comprehensive 8-page document you can download from our website that has information regarding what it means to be a carrier, what kind of issues, health issues we can face, and what kind of treatment options are available. We also have documents that are helpful for medical providers, where we encourage patients and carriers to go to our website, download these. We have one for patients with CGD to explain what CGD is and what kind of specialists or treatments are recommended. And we also have one for X-linked female carriers to share with their providers, because we often are faced with situations where we're visiting a medical provider or in an emergency room where many medical providers are not familiar with CGD. And this is a really handy tool to have with you to quickly and easily explain what these conditions are. We do a lot to advance research as well. If you go to our website, you will see the work that we've done to date. And we're very proud to have worked on the survey study that Dr. Leiding is about to present to us. Our website is www.cgdaa.org, and I welcome all of you to get in touch. Thank you so much.
Wonderful. Thank you so much, Felicia. And I will be sure to share the link to the CGDAA website in the chat so that everyone can check that out if they would like to. All right, wonderful. Thank you so much, Felicia, for giving that update. And now I am so pleased to introduce our presenter for today, Dr. Jennifer Leiding. Dr. Leiding is the pediatric immunologist and allergy specialist at Orlando Health, Arnold Palmer Hospital for Children. Welcome, Dr. Leiding.
So thank you for the warm introduction, and thank you. I want to thank the IDF and also Felicia. We'll get into everybody's role here. But as Emma just described, I'm going to talk about some results of a recent study that was performed in collaboration with the CGD Association of America on behalf of also the PIDTC, which stands for Primary Immune Deficiency Treatment Consortium. So in addition to working in Orlando, I also am an adjunct associate professor at Johns Hopkins, and I lead the CGD project working team for PIDTC, which is how this effort kind of came to be, again, in collaboration with the CGD Association of America. And I've listed my email here. If anybody needs anything or they have additional questions, feel free to reach out. So this data is hot off the presses, is not published yet, but is really the outcomes of our survey, which we have titled Self-Reported Symptom Burden of Female X-Linked Chronic Granulomatous Disease Carriers. And I should say, you can see in the presenter mode, there are two Jennifer Leidings. The one that is with the camera off is actually Dr. Marianne Miranda, who is a fellow at the University of South Florida, who helped lead this project. I sent her my link so she could join our meeting, but it listed her as a presenter. But she is here, and I want to give credit where credit's due. Oh, hold on, let me figure out how, there we go. So in addition to my other positions, I'm disclosing that I'm also an employee and shareholder of Bluebird Bio, which is a pharmaceutical company that develops gene therapy. And in no way is anything that I'm talking about an opinion or have anything to do with my employment at Bluebird Bio. I'm also a speaker and consultant for Sobi, for Horizon Therapeutics, and for Farming. Again, none of which influence this discussion. So just to review, there's a few background slides here just to set the stage so we understand a little bit about CGD in general, what CGD carriers are, and what we think might be going on. So just to remind everybody, CGD is due to defects in any of these components of the NADPH oxidase system. You can see them kind of where the X is, X marks the spot of these different particular proteins that make up the NADPH complex, or in the newly described gene called CYBC1, which leads to impairment of production of reactive oxygen species or superoxide molecules, which you can see up here in the top right of the diagram. This defect leads to recurrent and or severe infections with certain types of bacteria and certain fungi. It also leads to granuloma formation and then high rates of inflammatory disease, which we call either inflammatory or autoimmune or autoinflammatory. It's sort of called different names. And this especially affects the GI tract or the gut and is what we refer to as CGD colitis, the lungs and the liver, in addition to many other organ systems. So the diagnosis of CGD, it's frequent. This is old data, unfortunately, but we think the case rate's around 1 in 100,000 to 1 in 200,000, depending on which population you're looking at, depending on marriage, if there's intermarriage between families or small communities. And the presentation is typically in childhood, but there's definitely more adult cases being recognized with patients, doing better and living longer. They may go off into adulthood before being diagnosed. So just talking about types of CGD, this has changed over time. X-linked is still by far the most common. And then obviously women who are related to these boys can be female carriers, whether they're moms, aunts, sisters, grandmas, depending on, the different generations. And then I've listed the recessive genes as well as their frequency. The most common form of recessive CGD is P47 FOX deficiency, followed by the others. And then again, this newly described CYBC1 has been described in a few people. So talking about inheritance patterns, I found this picture actually very interesting because you can immediately target onto the X-linked inheritance where it refers to the unaffected carrier mother. And I hope that by the end of this talk, we can say that there is an affected carrier mother, because being a carrier is certainly meaningful. But you can see an X-linked inheritance, usually the female is a carrier and their boys have 50% chance of being affected by the disease. And their daughters have 50% chance of becoming a carrier themselves. And then the other 50% is not affected by the disease or not a carrier. And this statistic is true with each pregnancy. And then you can see in recessive disease, each parent is a carrier and is unaffected, and their children have a 25% chance of being affected by the disease or 25% chance of being unaffected by the disease. As you can see in the green and pink colors. So again, the X-linked inheritance is usually this female to male transmission, but you can, as I hope we show today, we want to take away this unaffected part because I find that not to be true in CGD. So how do we diagnose CGD? Many of you may remember this test, the NBT or nitroblue tetrazolium test, which basically uses a dye and a pathologist's eyeballs to look at the slide and see if there's a color change. And this color change is indicative of the superoxide that's being produced within the neutrophils. And so you can see in a CGD patient, there's no color because they're not producing superoxide. You can see what normal is, right? So all these cells have this black dye that's surrounding them. And then you can see in a female carrier that some cells are normal, producing the normal amount of dye, and some cells are not normal, where there's no dye or color change. And that concept is called lionization. Lionization means that each cell is expressing one X chromosome. And so the cells that have that normal color change are expressing the non-mutated X chromosome, and the cells that are abnormal and have no color change are expressing the mutated X chromosome. So how, most of us don't rely on the NBT anymore. We rely on the dihydrorhodamine assay, and that's probably how many of you all were diagnosed or your children were diagnosed with CGD. It really relies on the same concept. It's just replacing a human's eyeballs with a machine. And so you can see that with the DHR, you really isolate these different cells called granulocytes and you stimulate them. And then during this process, the cells are tagged with the fluorescent tag. When they're superoxide produced, they fluoresce. And so that fluorescence can be detected by the machine, and it directly correlates to the amount of superoxide being produced by the cell. And so what we get as a readout when we get these reports looks something like this. So you can see normal, we have this nice fluorescing peak that occurs after stimulation. You can see in a X-Linked CGD patient where they have little to no superoxide production, there's no movement of this peak after stimulation, so there's no fluorescence. And then you can see in the carrier, they have two populations. They have this normal population, which is on the right, and then the abnormal population, which is on the left, which is the same concept as the NBT, where we have these two populations, one normal and one abnormal. So what do people with CGD have major problems with? So on the left is listing the infections. These are primarily with bacteria and fungus. They don't typically have problems with viruses. And you can see the types of bacteria that and funguses that are the most common. This is in North America specifically, and then the locations within the body that they like to go to. So for example, Staph aureus is commonly found in the liver, lymph nodes, skin, and bone. Serratia notably really likes to go to bone, and so forth. And then CGD inflammatory disease. So this is by no means comprehensive. I've just listed the most common of what we see in CGD patients. By far the most common is the gastrointestinal, where we see colitis that happens in around 50% of patients to varying degrees. It can be very severe and life-threatening, or it can be mild. We see a lot of dermatologic disease like discoid lupus and granulomas of the skin, a lot of liver disease, including non-regenerative hyperplasia, and then pulmonary disease, which can be, again, granulomas in the lungs or interstitial lung disease. But you can see pretty much every organ system is affected with some frequency of either autoimmune or inflammatory disease. Okay, so talking about carriers of X-Linked CGD. So again, I'm just showing the DHR, how we have these two populations. And so these populations can be important. When I was in medical school, we were always taught that when a female was conceived inside her mother's womb, that this degree of lionization was dictated right at that point of conception. And so the percentage of cells that expressed X number 1 or maternal X and X number 2 or paternal X was dictated right at that moment. We now know that that's not true, that this ratio can change over time. And we don't know what influences that rate of change and who it affects more than others. But we do know that it's not fixed. So that presumably occurs in CGD carriers, that their rate of certain cells expressing one X chromosome versus the other can potentially change and further may need to be monitored. So previously, X-linked carriers have been described as the most common symptoms being discoid lupus, mouth ulcers, and joint pain. We've known that for a long time, and we've known that those are the primary symptoms, but we haven't known much more about it, nor what causes it. There was a beautiful study that came out of the NIH, now several years old, that was able to show that the DHR positivity, that being the normal amount of expressing cells that are expressing this dye, this fluorescent change. So this is considered the sort of the normal population, that correlates with developing autoimmunity or infections. And so you can see specifically in this infections arm, which is the most left column, that when your DHR positive cells fall below about 20%, in carriers, that's when they start experiencing infections that are related to CGD itself. So we're not talking about common stuff like common colds or common infections. We're talking about CGD related infections that shouldn't be happening in the general population. What came out of the study, though, that was, in my opinion, more interesting, was showing that the DHR positivity does not correlate to the development of autoimmunity or other symptoms. And so you can see specifically in this autoimmunity column, it's all over the place. It doesn't matter if your DHR positivity is normal, if it's abnormal, if it's somewhere in the middle, those patients are still getting inflammatory disease. So in general, in addition to this is just some of the other things that have been published about X-linked carriers over the last several years. We know that there can be some susceptibility to CGD-related infections. We know that there's immune dysregulation and autoimmunity, and the most common symptoms reported, at least in the literature right now, are lupus, discoid lupus, aphthous ulcers or stomatitis. We do see some GI disease, so colitis, and arthritis. We know there's some immune abnormalities in X-linked carriers, and this includes low IgG, which is what hypogammaglobulinemia is, and then some increased cell quantities, some of which, at least in this particular manuscript, were correlating to the development of immune dysregulation, or they were trying to hypothesize that these immune abnormalities might be related to the development of immune dysregulation. There was a beautiful quality of life study that came out of the UK showing increased rates of anxiety, higher rates of depression, lower self-esteem in X-linked female carriers. And they had a control group, so they were really comparing it to the general population and showed that it was definitely higher in those patients. So what we sought out to do was to really describe the symptoms of X-linked carriers from who better themselves, but the patients. And so through Felicia's foundation and the Primary Immunodeficiency Treatment Consortium and Dr. Miranda, who's pictured here, so now you can see her face, we developed a survey, a 57 question survey, so pretty comprehensive, that was IRB approved and administered through the CGD Association. And we ended up with 171 respondents. So I'm going to go over that data. The data that was gathered included demographics, method of diagnosis, medical history, utilization of medical care, and treatments. And our goal and objective of the study was really to identify the different symptoms that patients had, but to also really put a flag in the ground to say that being an X-linked carrier is its own disease, and that it's time that we recognize it as its own entity, because it's going to need its own treatment, its own recommendations, its own follow-up. And that's what we hope to gain when we publish this report. So I'm going to dive right into the data. Feel free to add questions to the chat if you see it. And this data is, I should preface this is unpublished. It's not peer reviewed. And it's still in the process of being analyzed and put together in a manuscript. So it may change depending on further analyses. But you can see from the figure on the left, we asked what the relationship was to patients with CGD. By far, more than 70% of patients were the mom of a CGD patient, but we did have some daughters, aunts, sisters, grandmothers, etc. We even had some that were not related. So they were carriers, but didn't have a child with CGD. And then we asked how they were diagnosed. So the majority of patients were diagnosed with a DHR, but we did have this small subset with the NBT. And then a really large group were diagnosed just with genetic testing alone, presumably because their children had genetic testing. When you see at the title of all of these different graphs where it says N equals 151 or N equals 153 on the right, this is the number of people that responded to this question. So despite having 171 responses, not everybody answered every question. So we have to take that into context. All right, so we asked about the education level of X-linked CGD female carriers. You can see by far the group that answered the survey is highly educated. So the majority of people had either bachelor's degrees or even post-bachelor's degrees, like a postgraduate degree, master's or doctorate. There were some that had technical degrees or high school education, but obviously, you can see by this graph, a highly educated group. And we asked about their employment status. Around 50% of patient respondents worked full-time, some part-time, some self-employed, and some not employed. We also asked, you can see in the far left graph, we asked each respondent to classify their own health, what they thought. Did they think they were in excellent health, good health, fair health, poor health, or very poor health? The majority said good health. So I found that kind of reassuring, that despite the fact that we were having all these symptoms, carriers felt that they were in pretty good health. That being said, there is a fair amount, so around 34 patients that had impairments in their daily living, daily activities. So daily activities include things like just getting up in the morning and cleaning your house and showering and brushing your teeth, just being able to sort of function on a daily basis. And then a subset also had restrictions in their work. Despite working, they weren't able to work at their full capacity. And so we asked them why that happened. And you can see in both sets, the majority of it is fatigue, pain, including painful joints, psychiatric symptoms, specifically on the left, some systemic conditions. We didn't ask to specify what those are, so I'm not sure. And then again, some sleep disturbance. So by far, though, the commonality between the two is the fatigue and pain. And then this graph really is just a summary of the overall clinical manifestations that patients had. So I go into much more detail about each one, but you can see based on every organ system, whether it's present, which is in black on the right, or not present. And these are absolute numbers. This is not percentages. So we're looking at the number of individuals who had, for example, skin disease next to dermatologic. You can see way more respondents had skin disease than not. But the same is not true for infections. Way more did not have infections than did. So that's how you would interpret this graph. And the ones that stood out the most were the dermatologic symptoms, the gastrointestinal, musculoskeletal, psychiatric, and then rheumatic or autoimmune disease. I'm going to go through each of these in my next slides, but just keep that in mind as we're looking through them. What were the most common just overall were the ones that we would have suspected based on the current literature. So you can see infections in X-Linked CGD female carriers. So 139 people answered this question. A large percentage had no infections, but in those that did, you can see how it fared out. So a lot of skin disease, a lot of pneumonia, a fair amount of cellulitis, which is also an infection of the skin, some deep infections, so deep tissue abscesses, and lymph node infections. Those were the most common you can see on the group. We're in the process of figuring out what the organisms were that caused pneumonia, because we want to understand that and see if that's CGD related organisms specifically. A fair amount of patients were also receiving prophylactic agents. And so we asked specifically about antibiotics. Around 30%, 25 or 30% were receiving antibiotics. A small number were receiving antifungals, and an even smaller number, although a few, were receiving interferon gamma prophylaxis. And then there was also a small group that just didn't know if they were receiving medications or not to prevent infections. All right, I'm going to walk us through each of these organ systems and just point out kind of the high-level highlights. Again, keeping in mind what were our most common. So the most common, I think, appear first, but just so you can look. And so each organ system, we asked very specific questions about different types of symptoms or disease manifestations that patients might have. So you can see the skin breakdown here. Of those who had skin disease, this is what they reported. So around 50% of the people that reported skin disease said they had a photosensitive rash, which is a type of rash on the face that gets worse in sunlight. We also had some delayed wound healing, which is common in CGD. We also had excuse me, discoid lupus, some alopecia, which is loss of hair, and cystic acne, which is also common in CGD. I should have prefaced all of these symptoms that we're asking about are common in CGD. So we're trying to see if X-linked carriers are also exhibiting these symptoms. Gastrointestinal, you can see a very large percentage of those with GI symptoms had oral ulcers, again, as has been described in the literature. A smaller degree, but not, of importance, had inflammatory bowel disease, or what we would call CGD colitis. A large percentage also had irritable bowel syndrome, and some with chronic diarrhea. So again, pretty common within this group. The genitourinary or fertility manifestations were also asked about. You can see there's a fair amount of miscarriage in this group. Miscarriage in general is hard to quantify. It happens frequently in the general population, so it's hard to know if we can attribute this to being a carrier, but we do know that in immune deficiency diseases or genetic diseases in general, there's a higher rate of miscarriage when there's a genetic abnormality that's inherited. So this may be meaningful. It's hard to know at this point. There's some degree of infertility. We also see recurrent urinary tract infections and some kidney disease. Looking at hematologic manifestations, so this is the blood. A lot of patients reported that they had anemia. A fair number also reported low white blood cell count. That's what leukopenia is, and low platelet count, which is what thrombocytopenia is. So we're seeing some low counts in these patients. We also asked about bleeding disorders or lymph issues. So a fair number had chronic lymphadenopathy. And then we asked about bleeding related to menstruation or not related to menstruation. And a fair amount had excessive bleeding related to their period each month, but some had bleeding even without menstruation or bleeding issues. Pulmonary manifestations were actually not that common. The majority of it was pneumonia, so infections in the lung. But a fair amount did have some of these that we see in CGD patients, a small number with interstitial lung disease, a few with pulmonary nodules. Pleurisy is painful. It's inflammation of the covering of the lungs and is what people refer to as like a stitch in your side. That's usually pleurisy, is what we're reporting here. And then a small number also had granulomas in the lungs. Eye manifestations. So we looked specifically for that. You can see a good chunk of patients had chronic dry eye, but again, not very common for the rest of the inflammatory manifestations we asked about. And then looking at musculoskeletal and neurologic, there's a bit of overlap here. You can see a large group report headaches, chronic headaches, and arthralgias. Arthralgias means painful joints, but not necessarily swelling or warmth surrounding the joint. It's just painful. So a large group reported that. And then when you look into the rheumatic conditions, we do see a fair amount of arthritis. So rheumatoid arthritis reported, and then other types of arthritis. And the difference again being arthritis is swelling or warmth of the joint, not just pain. There was also a subgroup of patients with lupus, thyroid disease. We see Raynaud's phenomenon, fibromyalgia, and some of the other autoimmune conditions as well. And then lastly, we asked about psychiatric symptoms. And so again, remember this is self-reported. So these are patients reporting what they've been diagnosed with. We see a really high percentage of anxiety. So around 70% of patients are reporting that. Also a high amount of depression, panic attacks, post-traumatic stress disorder in carrier women. And it's hard to know what to attribute this to, if this is a genetic susceptibility to these disorders, or the fact that they're living with a chronic disease, or the fact that they're family members of children in a lot of cases that have a chronic disease. Could be contributing to all of this. So I showed you a lot of data, and I'm happy to answer questions about it, but I think our major conclusions that we've come up to at this point are listed below. I should start with the limitations. So every study has its limitations, and ours is not different. One of the limitations is that these are self-reported symptoms. So we are not verifying these facts. The people answering these questions are not necessarily medically trained. And so there's no way for me to prove, if a person said they had anemia, that they in fact had anemia. So there's something to be said about that. And then we don't have a healthy control group. So we don't know, how, we have nothing to compare to as far as how frequent these symptoms are happening. We can look in the general population, but that's not comparing similar age-matched and sex groups. So that's certainly a limitation. But in general, what we've found, at least from the data thus far, is that CGD female carriers can have CGD-related infections, and many require antimicrobial prophylaxis. There is clearly every organ system is affected in some way, shape, or form, with the most common being autoimmune disease and rheumatic disease, and then gastrointestinal disease. And there's a high amount of psychiatric symptoms. So, what the major points I want to make when we eventually publish this manuscript is, again, that this is its own entity, and that many of our patients need to be followed by specialty care. We do have that data within the survey. We're still in the process of analyzing it as far as how many carriers are following with subspecialists, but we want to encourage them to do so in the future. So with that, I'm happy to take questions, or Emma, if you want to take it over with what's next.
I know everyone is excited to get their questions answered, but really quick before we dive into Q&A, we are going to actually hear from our partners at Horizon Therapeutics. So I am excited to introduce to you Bridget from Horizon Therapeutics. Welcome, Bridget.
I will be very brief and give you all time to write in your questions to Dr. Leiding and Felicia. I know there's a lot of great stuff that was discussed today, and I just want to thank first IDF for putting on this event today and hosting such a wonderful platform and opportunity to have this really important conversation. And Dr. Leiding and Felicia, these survey results are incredible. Thank you for the work that you're doing to support the X-linked female carrier community or on CGD. Such an important conversation, and I just really appreciate the work that you all are doing. So like she said, I'm Bridget. I work at Horizon. We're a biotechnology company that's focused on rare autoimmune and severe inflammatory diseases. My role specifically at Horizon, I get to do this incredible work where I work with IDF and people like Felicia and just witness and see the incredible work that they're doing and bring opportunities to support it. So I feel very thankful that I get to meet a lot of really wonderful people and support great events like today. So thank you again for attending. Thank you IDF for hosting. Thanks Dr. Leiding and Felicia for spending time today. Hopefully you all have had some time to type in your questions. I know that Dr. Leiding and Felicia are happy to answer them. So with that, I'll turn it back to you, Emma.
Awesome. Thank you so much, Bridget. And again, we really appreciate having Horizon Therapeutics be a partner on today's program, and we are excited to dive into Q&A. All right. So our first question. So first off, someone asked if I could send any links or emails that we mentioned during the webinar, and we certainly will. I included the link to the CGDAA website in the chat, so feel free to check that out, and we'll make sure to include any relevant links in the follow-up email as well. So thank you. All right, so first question is, can daughters genetically test as an X-linked carrier if their mother is not a genetic carrier and their father was healthy?
Sure. So it's unlikely. There's a rule in medicine that we never say never. So it's unlikely that a daughter would be a carrier if her mother were not. But it's possible that it could be de novo or spontaneous in the daughter. And so if there's a family history of CGD, it's certainly worth checking.
All right, thank you, Dr. Leiding. Next question. For the common treatment options, antibiotics, antifungals, etc., has non-Western treatment been considered or researched, including transfusions, natural antibiotics, and supplements?
So yes and no. I know that there are patients that have utilized some of these, and anecdotally, I have heard positive results as far as sort of non-Western treatments, but none of these have been studied rigorously in a trial that's a placebo-controlled trial to show their efficacy. And so, what I usually tell patients is to use them with caution, and they're not intended to replace standard of care, antibiotics, antifungals, immune modulation that might be recommended by your physician.
Thank you. Next question. When you talk about CGD carriers being followed by a team of specialists, beyond immunology, what other specialists should someone see regularly?
Yeah, so I think it depends. Certainly an immunologist. Sometimes immunologists are hard to find depending on where you are in the country. And so it's important to know where who has the expertise to follow patients that are carriers. Sometimes it's a hematologist, oncologist, sometimes it's a rheumatologist. So I think one of those specialists at least needs to be the primary specialist for a carrier. And then if the carrier is developing symptoms, I think you start adding to that list based on the symptoms that might be present. So for example, if a carrier started developing inflammatory bowel disease, they obviously need to be followed by a gastroenterologist in addition to their immunologist. But I don't know that any of those need to be prophylactically or done or be evaluated in a proactive way. It's more when symptoms arise. At least that's the best we know as of now.
Thank you. All right, and thank you to our audience for all these great questions. We really appreciate everyone's engagement. All right, next question. Would you say that some of these findings might be able to be generalized to other PI carriers such as SCID?
Theoretically, I think that Each of those is going to have to be investigated in its own way. I don't think that you can take one disease entity and say being a carrier for this particular disease means that being a carrier for other diseases is as meaningful. Although I do think it gives credence to turning that concept on its side, that being a carrier does matter, specifically in CGD. So it's worth looking, but it doesn't mean that it will hold true. It just needs to be investigated further.
Thank you. All right. Next question. I am an X-linked carrier and I turned into an X-linked patient now. How will things be different for me after my diagnosis? Also, did I inherit this from my mom or dad?
So X-linked diseases are passed from typically from mom. So if a female is a carrier, she has likely inherited that carrier status from her mother. But the only way to totally verify that is to test mom, either with a DHR or with genetic testing. The other part of the question of what does that mean for you now? So once somebody, I'm not sure what the criteria is being used to classify somebody as an X-linked patient versus an X-linked carrier, so to speak. But based on what I would potentially use, that might mean just higher vigilance about avoiding areas that you might be exposed to certain organisms or infections, because your risk of infections is potentially increased, and being compliant with medications so that those infections don't happen. And then your primary immunologist or whoever's caring for you needs to just be sort of always on the lookout for development of symptoms surrounding autoimmunity if they're not already there.
Thank you, Dr. Leiding. All right, next question. What is the research behind granulocyte transfusions as a preventative measure for infection?
So there's there's actually a recent paper that just came out that talked about granulocyte infusions. So just to sort of level set, so folks know, granulocyte infusions are basically using donor white blood cells and infusing them into a patient. There's a lot of risk associated with that because it's a blood product. So we do know that when granulocyte infusions are used during active infection, they can help treat that infection. And in the majority of the literature or reports of this, it's used in very life-threatening situations where there's not really an option. And so another good option, I should say. And so granulocytes are used, and they can be effective at helping to eradicate that infection. I've not seen where they've ever been used prophylactically because there is, again, substantial risk associated with them. And the major risks associated include the passing of viruses from a donor to a recipient, and then also the development of antibodies against those white blood cells, which can make it very difficult to then undergo transplantation if that's something you're pursuing in the future. So I don't know that I would advocate using them prophylactically. Or that it's ever been done, but they can be effective during really, really life-threatening infections, again, where there's not a better option for treatment.
Thank you. All right, apologies if I butchered this pronunciation. Can granulomatous lymphocytic interstitial lung disease be reversed, or is it more slowing the progression of the disease down? And I know it widely depends on the person and how healthy they are, but do we have a median time frame associated with disease progression?
So whoever, you did a great job pronouncing it, Emma. Whoever asked this question, you somewhat answered your own question. So yes, it's a difficult symptom of disease. It really depends on the degree of progression and the chronicity of it, if any of it can be reversed. If it's caught early and immune modulating therapy is effective, there can be a small degree of reversibility, but it's usually once whatever the damage is done at the point that you start therapy, for the most part, is irreversible. And the idea is to really halt progression, like you mentioned in your question. And knowing the median time, I don't know that anybody knows that. And certainly I don't. As far as when that might progress further, there are some patients that never progress once they've been treated with immune modulation, but there are some that still might continue to have disease. So I just don't think we know.
Thank you. All right, I think we have time for maybe one or two more. So next question, if I don't live near a major medical center and I'm treated locally by a rheumatologist who doesn't know CGD well, would you recommend I travel you to an immunologist? The closest one is about 200 miles away from me.
Yeah, I think that it's great that you have somebody to rely on. But in my opinion, I think that it is worth at least having somebody who has more knowledge of CGD provide consultative care, even if that physician is communicating with your rheumatologist. And maybe you're seeing that immunologist once a year just because of the travel restrictions. But if there's a relationship that can be formed between that immunologist and that rheumatologist, then you're in better hands because the rheumatologist has somebody to reach out to. So I think it's probably worth at least establishing care. And I'm certainly sensitive to the travel restrictions, but that's, state of affairs.
All right, thank you, Dr. Leiding. And last question, was there any indication of higher levels of osteoporosis in CGD carriers?
I don't remember seeing that, but I don't know that we specifically asked that. We did ask about other forms of arthritis, but that's kind of a bucket statement. So we definitely saw high degrees of other arthritis. I'm sure that includes osteoporosis or osteoarthritis specifically, but I don't know that we asked that. So I'll have to go back and look. I'll have to pause for that.
All right, I think we're okay. There's so many questions, which again, we really appreciate this
Great.
engagement.
Yeah.
I'm gonna ask one more. All right. Let's see. What would the closest disease be that the medical community has used preventative blood transfusions that would be comparable with data from granulocyte transfusions?
Oh gosh, I don't know the answer to that. I don't know that anybody has ever used blood transfusions or blood products in a preventative way. They are used to treat disease manifestations. Common diseases that get blood transfusions are things like thalassemia or sickle cell, but in those patients, they have symptoms of major organ dysfunction before transfusions are even started. So I don't know that there is a case of that. So that's my best answer for that.
That's okay. Thank you. So we have a little bit more time than I thought. So if everyone's okay to keep going on questions,
Sure,
I'm gonna keep going through the box. All right. Someone asked, do some carrier symptoms get better or worse over their lifespan? For example, less frequent mouth ulcers.
So we didn't ask in our survey about the frequency of symptoms or the longevity of it, meaning like when did they start and when did they end and were there pauses. I think in my own clinical experience, I think that some symptoms come and go. I think it also depends on compliance with treatment. If people are doing the things that they need to do to combat those symptoms, they tend to be a bit better. But I'm not sure that we know the full answer to that to be able to say, what will be present and for how long.
Thank you.
Sure.
All right. Next question. Are you familiar with interferon gamma injections? I am receiving them 3 times a week. Can they cause nerve inflammation and/or muscle pain?
So yes, I am familiar with interferon gamma injections. The common side effects of interferon gamma include muscle aches and pains, usually in the 24 hours after injection. And so there's some recommendations about how to alleviate those symptoms, usually with taking things like Tylenol or Motrin. So I would advise you to talk to your doctor about that. And then as far as other inflammation of the nerves, there is neuropathy that's reported in the use of interferon gamma. It's one of the side effects that's listed on their package insert, but I don't know that it's specific to inflammation of the nerves. So I think it's probably worth bringing up with your doctor that you have concern about it, just to make sure they're not just blaming it on the interferon gamma, but also kind of working you up to make sure there's not something else going on.
Awesome. We have about 3 more. Do we have time for those?
Sure.
Okay, awesome. Thank you. All right, next question. What do you attribute the higher incidence of psychiatric symptoms and what would help?
Yeah, I think I mentioned it a little bit in my presentation. I don't know that we are going to have the exact answer. I think just by thinking about this, we do see a lot of psychiatric symptoms in patients with chronic diseases that have been reported in just in general, and all forms of, all different types of diseases affecting different organ systems. We also see an increased risk of or presence of psychiatric symptoms in caregivers of family members who have a chronic disease. So I think this is a unique situation where the majority of our respondents are carriers who are reporting their own medical problems, but in the majority, they are also parents of children who have a life-threatening immune deficiency. And so all of those concepts taken together it's probably multifactorial, that we're seeing it because of being a carrier yourself, having chronic problems yourself, but also being a caregiver for a patient, for a family member with a chronic disease, and that family member being your child. So I think that that's likely the source. Now, what can be done? I don't know what can be done to prevent it. I think that's going to be difficult. But what this data tells me is we need to do a way better job of screening for it, and getting carriers the help they need, whether that's, psychotherapy or a psychiatrist, or, just an outlet for these types of symptoms to help treat them.
Thank you. All right. Next question. I don't recall seeing literature on neuromuscular symptoms in carriers, but it seemed to be highly reported. Will there be further research into incidence of diseases like fibromyalgia or neuropathy in carriers?
Well, I hope so. I think that this is a start. Our goal of this was to, again, like I said, put the flag in the ground and say, this is what we're going to do. But we, I hope that by reporting all these symptoms, it will inspire, young scientists and clinicians to really delve into the mechanisms of why these are happening. So I'm going to say to be continued.
And then this seems like a natural follow-up and a good one to end on. Now that you have analyzed the result of this study, do you have plans for a follow-up?
We have plans to publish. That's my first goal. So Dr. Miranda, who's I think still on this call, has a lot of work ahead of her to get this published. We're hoping that we'll get it in and sometimes publication can be a long process. So hopefully we get that out. And then, yes, I think this could lead to potential follow-up studies and really delving into this. I know that Felicia and the CGD Association right now are working on developing a quality of life study. So more to come regarding that. And I think that's a bit of a spin-off of this and some overlap with this group as well.
Definitely. Well, I think that was a good one to end on. So we will close out Q&A with that. Thank you so much to our audience for all your engagement and your questions. That makes these lunch and learns a lot more fun when people are engaged and interested in what we're talking about. So we love to see that. So thank you so much. And again, there we go. Thank you so much to Dr. Leiding for this wonderful presentation, to Felicia for sharing her updates, and to Bridget and Horizon Therapeutics for supporting this program and being a part of today's talk. Thank you so much. All right, so we hope you'll remember to take advantage of all of the resources that IDF has to offer. To explore our resources for CGD, visit our website and search CGD, or visit the Resource Center, where we have everything from videos of past presentations to stories from real patients on our IDF YouTube channel, and even podcast episodes on CGD. I also want to make sure everyone knows about our official IDF Facebook page for the CGD community. It's a private group with over 150 members, and we definitely encourage you to check it out or join if you're interested. To our audience, if you have additional questions about CGD or anything PI related, you can ask IDF. We encourage you to go to www.primaryimmune.org/ask-IDF and ask your questions, or you can also give us a call at the number on your screen. Oops. We want to close by saying that all IDF programming is truly guided by the individuals and families we serve and the PI community. So we hope you will take our very brief program evaluation survey, which we will email out to everyone after the program today. And lastly, we hope you will join us for the next IDF Lunch and Learn, where we will dive into a congenital athymia 101 session with Dr. Elena Shea from Children's Hospital, Colorado. Thank you so much again to Dr. Leiding and Felicia and Horizon Therapeutics for being a part of today's program. And thank you everyone for your engagement and participation. We really appreciate it. I hope everyone has a great rest of your day. Thank you.